Welcome to the new iWorld Live studio as our premiere, our champagne cracking on the hull of this great ship. We have we have George Waring the Fourth, whom I love speaking with. I know that you're going to teach me a lot today, and I can't wait. So, George, we're going to be talking about a new technology, new implementation of a technology, which is anterior segment OCT, but it's intraoperative anterior segment OCT. So describe for me what this technology is and what its role is. And then you're giving a wonderful talk, very eager for, on comparing the information that we gather from intraoperative anterior segment OCT with traditional preoperative biometry. So take it away.
Well, first off, Josh, thanks so much for the opportunity to be here. This is really exciting. We love the new format. We just couldn't be happier for you all, so congratulations. We're learning more and more about image-guided surgery, and this is something that we now have access to advanced tools like OCT with pre-op information, but we can also use this intraoperatively. And we set out to look at 600 consecutive eyes with intraoperative OCT during cataract surgery. So my colleagues, Dr. Carolini Hosha, Dr. Luisa Govea, and Dr. George Haddad, two of our fellows, and my partner, Dr. Rocha, looked at this biometrically. And essentially, we're trying to figure out, is there something there or not that we can actually utilize to help predictively and help us really truly understand the landscape of biometry as it relates to intraoperative factors. So what am I talking about? Let's just think of some of the main things that we evaluated. 600 eyes, consecutive intraoperative OCT for cataract surgery. So we evaluated something called LMP, all right, which is essentially the lens meridian position, or the closest surrogate we have to this elusive effective lens position. And at the end of the day, Josh, that's what this is all about. It's trying to predict effective lens position. And now we potentially have the intraoperative technology to do that. So what we want to do is to say, okay, well, how does that correlate to things like anterior chamber depth or axial length? Likewise, how does lens thickness correlate with these other parameters? We think we know, but do we really? So ever since we started doing intraoperative imaging, we realized that when we always thought these large eyes would have big capsules, and that's why you might have rotation of toric lenses more often, we were not observing that at all. In fact, in many cases, it was the opposite. The large eyes had smaller capsules, and small eyes had larger capsules. So that's one of the reasons we set out to do this. And sure enough, when we studied it, the 600 eyes, there was essentially zero correlation between lens thickness and axial length. So I have hypothesized that a potential rotation may not be from a large bag in a large eye. It may be the actual force of a thin-walled sclera and thin-walled cornea, perhaps, and that is more likely to have almost like a torque with a piston-like effect that allows a rotation.
That's really interesting.
Not a large capsule, and that's a hypothesis, but we have the data now to support it. Furthermore, there was a massive variation in lens thickness, basically 100% variation, meaning we went from 3 millimeters thickness to 6 millimeters thickness. So total variation there. And then in terms of the highlights of correlation, we found a strong correlation with lens thickness and anterior chamber depth, lens meridian position, and anterior chamber depth. So both of those were strongly correlated, but they were weakly correlated with axial length. So we really think that there's something there. So Dr. Gueva recently, and she's presenting this here at ASCRS, went and looked at postoperative data with swept source OCT, and it turns out that postoperative lens meridian position, where the IOL ended up, correlates strongly with preoperative crystalline lens meridian position. So all of a sudden, we have a direct correlation that we can count on pre to post with essentially what is effective lens position. And we've gone one step further, and we've described a new metric called the equatorial plane position, which is essentially a chord between the lens meridian position and the anterior capsule. So we're looking at advanced, how this may fit into advanced formula that will actually take intraoperative information and perhaps help us understand how we can predict where the lens is going to end up.
This is fascinating stuff. Let me ask you this. So the study is. I just want to be clear, and then I've got a few follow-up questions. The study is to use the intraoperative anterior segment OCT to gather data that you are then. So it's not that you are adjusting your lens calculations on the fly currently with anterior segment OCT. You're using it to give you information about the import of the different preoperative biometric characteristics, with the idea of coming up with number one, better understanding, and number two, better lens calculations.
Precisely. We thought for years that one size doesn't fit all, and we actually studied this probably about 15 years ago and wrote a big white paper for industry trying to figure out intraoperative lens capsule volume measurements, because we knew that it just doesn't make sense. I mean, it'd be like having a one-size shoe.
Yeah.
For all the different size feet. It just doesn't make sense. And we have these concerns about rotation. We have these concerns about our outcomes being essentially, we expect a half a diopter in terms of our intended refractive target with average cataract surgery. That's what we're going for. But guess what? I could just flip a coin, and you got about a 50-50 shot of landing within a half a diopter of your intended target. If you look at the best peer-reviewed literature, you've got a 55% chance of hitting a half a diopter. And that's all related to effective lens position and how little we really understand about some of this dogma about lens volume, for example. I mean, how many people here do you think say, well, lenses rotate in highly myopic eyes because those capsules are bigger, those big old capsules? We hear it all day long.
Yeah.
We found that not to be the case.
Yeah, fascinating. So let me ask this then. Did you find any correlation between the preoperative meridian tilt and the postoperative cylinder?
That's a great question. We have not looked at that yet. However, Mitch Weichert has looked at that, and he has found that. And that's a very important finding, actually. Excellent question.
Yeah, I mean, it would be not the equivalent. It would be an astigmatism of oblique incidence. Now, one last question. I mean, frankly, first of all, it's a fascinating topic. Second of all, I'm a geek, and I could talk about this for the whole day with joy. So what I'd like to know is, in the post-operative effective lens position studies that you've done to sort of follow this up, how far post-operatively were those patients? And the reason that I ask, and it's turning out to be a really clinically important question, is that Doug Koch has shown that there can be a clinically important movement of the intraocular lens even a few months after surgery. And that kind of throws some cold water on the idea of doing intraoperative aberrometry to determine the lens position, because all that's telling you is the lens position while you're sitting there in the OR may not reflect what's going to be the case for that patient 3-6 months out.
Yeah, excellent point, and very well received. I couldn't agree more. So we looked at this at a month and 3 months, and I 100% agree with Doug, because we're using second eyes to kind of calibrate personalization of perhaps a second style lens based on how somebody did with the first lens, but we really don't think that is clinically meaningful, because of exactly what Doug has stated, that your healing factors have not occurred yet, so you really don't know where the lens is going to end up. And that's whether it's anterior, posterior, oblique, like you mentioned. And we know that a millimeter can have a 2.7 diopter effect, right? That's massive,
right,
with just a millimeter
the
anterior
tiny tolerances here.
Movement. So that's, we ran a beautiful session yesterday on postoperative lens adjustability. And it was a heated debate that was just wonderful about, well, we're only so good, and we can do better, but ultimately we may need to have an answer afterwards because
Yeah.
of some of not being able to truly predict ELP because of some of these things, and not until we can truly eradicate lens epithelial equator epithelial cells, primary posterior capsulotomy, and some of these other factors will we truly be able to answer some of these questions.
Yes, absolutely fascinating stuff, George. I can't begin to thank you for bringing this wonderful topic to us. And I can't think of anyone or any topic that would have been a better debut for our new studio. George, I want to thank you very, very much for sharing this with us, for being so generous with your time. And I want to thank you, our audience, for participating in this live debut of our new iWorld studio.
Thank you, Josh. The honor was mine.